if you've been having sciatica longer than 4 months, you're already prone to having that chronicity last well into a year or even 2 years, there's some research showing. They have seen 3 or 4 doctors, and all of them probably prescribe some medication of some form, and they're just waiting for surgery. None of them truly addressed the issue at hand. And so that's what we're trying to today explain to you guys is what can you actually do in the short term and also the long term that will effectively manage this and not have you wait miserably for years on out without any results.
And that's where you have to know what tissues or structures are involved so you can start healing those, whether it's time under tension, whether it's small rotational holds and isometric contraction squeezes with either tapping of the area so you have that mind-body connection for the healing of that specific level. Like you can go very in depth with some of this, especially like core to extremity movements, meaning anytime you move, walk, throw, jump, all the movement usually starts with the core and then bleeds out to the legs or arms from there.
I had seen pre and post MRIs of patients getting cortisone injections, and I did see on the post MRI 6 months where usually we want to see a huge regression. There was absolutely no change in the disc protrusion via a cortisone injection frozen in time.
Welcome to the Functional Code, your go-to source for decoding optimal health. Join Dr. Addy and Dr. Jace as they break down the science behind pain, performance, longevity, and more, making complex concepts easy for you to understand and apply in your life. Your journey to a healthier you begins with understanding the Functional Code.
Welcome back, everybody, to the Functional Code. We have an exciting pod for you guys today. Super excited to bring this to you guys. We're going to be talking on the complete guide to herniated discs. We're going to talk all about this low back issue, neck issue if you are having it. We really just want to make sure that you guys understand how to manage this issue. It is highly complex, and there's a lot of information out there that can be confusing and completely wrong when managing these issues. And so we want to make sure that you guys have the correct information when going through and taking care of this if you need to. And yeah, we're just super excited to bring this one to you guys. As always, I am Dr. Addy.
And I am Dr. Jace. Yeah, today we're going to be going over a bunch of stuff, especially if you have lower back pain, if you have neck pain. Some of the stuff that we're talking about today could be a result of that discomfort. Now we're going to dive into some deeper areas, but making it understandable for everyone, providers and or the general public. We're going to be going over these certain things that can make the outcome worse. We're going to go over different things of the surgery effectiveness for discs, also into other different orthopedic procedures, and can discs, herniated discs or bulge discs, heal on their own. That's going to be incredibly important that not a lot of people know about. Some conservative areas of treatment, and then we're going to even dive into our steroids or cortisone shots. Are they effective for discs? And you're going to find some surprising stuff with that. Some of the stuff we brought up a little bit in the past, but today we're taking a little bit more of a deep dive down to explore some of the information. There's a lot of research that we have in this area that Doc has accumulated over a period of time, and we're just compiling it all together. Doc, thank you for that, and let's dive into some of the risk factors, incidences, and go from there.
Yeah, the main things that you want to understand that contribute possibly to the chance of getting a herniated disc are really 4 major ones. Number 1, obesity. That's going to be already not only a huge driver in herniation, but also just in increasing pain. They've found that those with obesity have a lower pain tolerance, so they're more prone to just having pain all around. And then number 2, if you've already had a herniation prior, there's a higher chance of it happening again. Again, this is back to us talking about when you have an injury, you want to make sure that you heal it fully. Otherwise, the chance of it coming back is higher. Number 3 would be diabetes. Heavily contributes to the chance of a herniation. And not only that, but a poor healing herniation, and one that is going to be there for longer than you're wanting, especially if you're trying to take care of it and heal it. Because already diabetics are poor healers, and that's going to be something that's going to be resistant to improving in care. Smoking heavily contributes to the chance of herniation. And I know that I think if there was one that was the highest direct chance cause is smoking. Smoking is going to be
see that.
that. So yeah, I think for most who are dealing with this, the ones that have come in, they're usually a little more overweight. That's very common. They tend to be in a profession where they maybe been a flexion based for a long period of time, so they're bending over or lifting a lot of weight. There's a lot of reasons to why this can occur. Especially, we even had a gentleman who worked in a lab and had his neck was looking down, at lab equipment for many hours, and he had a horrific herniated disc. The thing was miserable. And so we just want to make sure that if you guys have any of these, or you're curious to making sure that this, if you ever had a family member who has gone through this and you're like, this is something I would never want to go through, this is something that you guys should listen to moving forward in the pod, because we do have some really great information coming up as far as how to manage this effectively if it does happen, how to make sure it doesn't come back, and what things you should absolutely avoid, because there are some things that are not going to add to your benefit. So before we jump into that, Doc's going to go over really the anatomy that's involved in today's pod, because we want to make sure that you guys understand the verbiage, what we're about to talk about. And that way, if we do end up stating some of these words, you at least have an understanding of what that means. So Doc, if you want to jump into that.
Of course. So when you look at disc herniations, disc bulges, it can often happen more in the lower back or potentially even the neck. Not oftentimes we see disc bulges and herniations in the thoracic spine or mid-back, mainly with how the joints are set in, more going vertical. So that's where, when we look at neck, lower back, lumbar disc herniations, that's where when you have two bones, there's a disc in between. Anytime there's weakness or laxity and lack of stabilization locally around either that segment or coupling of segments above and below, there could be weakness in the spine, thus forcing a bulge or herniation of that disc, more times than not backwards into the spinal canal. Now, there's some people that are living with disc herniations, disc bulges with no pain, and it's one small type of movement that causes all this weird pain. So if you ever noticed you bend down and then pain all of a sudden started, like for some people, really bad, oftentimes it could be due to a disc. There could be a bunch of other things involved with that. Going back to what Dr. Addy said, especially if there is degeneration in the spine. With gravity placed on the body, whether it's compromise of the system, it then will also lead to more pinching off of the nerves as they go out of the spine and down to the legs. When we look at this, there's an area known as the spinal canal. So if we look at this either bottom up or top down, how the spinal cord travels down, if there's a lack of space in the spinal canal, that will also have a higher incidence for leading to disc bulges and or guarding, and then can lead to compromise or compensations above and below where that could be. So that's going to be another thing involved. But more times than not, when you go to a practitioner, if you're in pain, they want to see, where's the disc bulge? Is it coming straight backwards? Is it going off to one side? And there's a few different ways of treatment that we'll get into later in terms of pumping that disc back into place. And we'll also answer the question of, does it heal on its own? So that is a few things involved. There's definitely joints and facets around the area on the back side, especially lower back, and then also neck. So that's going to be involved there too. But main thing is paying attention to the discs and where they go out, and then some of the other risk factors involved, whether it's degeneration of the bones, the discs, the facets or the joints, or compensations above and below the area.
Absolutely.
Yeah.
And the main thing I think people associate herniations with is leg pain or pain down the leg.
Yes.
And we call that sciatica.
Mm-hmm.
And this kind of leads us into our first topic here, which is a great study that was labeled, "Why are there no drugs indicated for sciatica? The most common chronic neuropathic syndrome of all." And this study really broke down, it was more of a informative piece saying, we don't have any FDA-approved drugs for sciatica. And so for those of you going into urgent care ER, expecting to receive a med that will take care of sciatica, you are misinformed, because the only thing that they can give you is some drug that can off-label be used for your pain. And sometimes it works and sometimes it doesn't. And there are times where they don't even give you a painkiller, they'll just give you a muscle relaxer, which usually doesn't even touch what you have going on. So
Chemical versus structural.
exactly. And so with some of the medications that they included in these trials, really all of them showed limited effectiveness and really very great efficacy. And anything from even NSAIDs all the way up to painkillers, none of them had any significant benefit to treating sciatica. And again, just so that you guys are aware, sciatica is when the disc, this is one cause of sciatica, but is when the disc herniates far enough out and effaces the nerve. And the nerve then is, when a nerve is contacted, more often than not, it starts sending signals, and you then feel tingling, numbness, pain, and they can be quite debilitating if the herniation is large enough.
And some of that can go, if you feel pain all the way down to your feet, oftentimes it can be coming from the spine, whether it's one leg or two legs. So Doc, going back to your point, especially with the question of why do drugs not affect sciatic pain? I know we brought this up just a little bit ago in terms of structural versus chemical. Oftentimes, if you're taking NSAIDs or you're taking different types of drugs and it's not affecting the pain at all, it's oftentimes you don't necessarily want to, for most people, go to the next higher drug. You want to start thinking outside the box. Okay, maybe drugs from a chemical standpoint, will it actually affect the pain? And that then goes to, we're going to get into a few of these other treatments of how can you affect the structure to help with the pain. There's way better results. So it's almost fighting fire with fire to a certain extent. But that's just more or less the reason why. Because if you have a chemical imbalance, but there's a structure problem, it can maybe downregulate the pain threshold, but it's not going to completely get it away long term. And that's where some of these other therapies will come into play. Now, Doc, with some of the common outcomes that we find with some of these disc herniations, disc bulges, what have you found with that?
So this study, I'll have you guys, or I'll have you throw it up. I remember this study was really helpful for predicting who is going to have worse outcomes, just given by the symptoms that they were having. And so they divided these patient groups into 4. And the first group was those who just had mild back pain and mild leg pain. The next group was moderate back pain and moderate leg pain. And then the third group was mild back pain, but really bad leg pain, like severe leg pain. And then the cluster 4 was, the last one was severe back and leg pain, which represented obviously the most disabled group, the distressed group. And what they found was the last group, group 4, that had the worst outcomes over 2 years, which makes sense. They were having the worst symptoms. But they also showed that clusters 3 and 4, both the one with severe leg pain in cluster 3 and then severe back pain, leg pain in 4, made up of about 42% of the surgical cases.
Wow.
With respect to who's going to possibly not need surgery, but who is going to be pushed into surgery is going to be the ones that have more leg pain associated with their herniation, and of course how severe the pain is. We also know, and I think this is coming up too, that if you've been having sciatica longer than 4 months, you're already prone to having that chronicity last well into a year or even 2 years, there's some research showing. So the goal is to try to limit the pain and try to improve yourself within those first 4 months, just so that you aren't giving yourself this chance of having it last longer. And there are patients who have come in with chronic sciatic pain, which they've mentioned and said that their issue has been going on for a year or two. And I'm so frustrated because I know what their journey was like. They have seen 3 or 4 doctors, and all of them probably prescribe some medication of some form, and they're just waiting for surgery. None of them truly addressed the issue at hand. And so that's what we're trying to today explain to you guys is what can you actually do in the short term and also the long term that will effectively manage this and not have you wait miserably for years on out without any results.
So true. And yeah, even going to that point, Doc, as we're diving into some of these things of what can help with sciatic pain, we're gonna go over a little bit more in depth on what, for some of these treatments, on what orthopedic surgeons would look to do. By all means, we're not surgeons, but there's a general understanding of treatments on how they would go about it. And yes, some of them are very invasive, that can have complications to not only the structure but also the nearby tissues, which we'll get into in here in a sec.
Yeah. I think we've also broken down just the concerns that you should have prior to, because it does set you up for a even bigger uphill battle after you go through with something like that too. And I think it's important to know that, because I don't think many surgeons even tell you. I doubt there are many surgeons that actually go through that and explain to you the real risks. They're going to go over the fact that you're going to have some possible infection chances with anything, but actual other things to worry about, we're going to get into in just a little bit. The first study that I included dealt with spinal manipulation or chiropractic adjustments. Not just chiropractors do manipulation, but I would say by and large, we probably share 90% of the market of those kinds of treatments. What we found was 60% of sciatic patients who didn't respond to other treatments, they all benefited from spinal manipulation, comparable to those undergoing surgery. Obviously, suggestion it's a viable option. Patients that had symptomatic lumbar disc herniations that were unresponsive to medical management, starting with spinal manipulation and reserving surgery for later can actually optimize outcomes, they found in this study. They also found that spinal manipulation and microdiscectomy both showed significant improvements in outcomes, indicating that the effectiveness was similar in both groups. So why would that be important? Spinal manipulation is very non-invasive, about as non-invasive as you can get. The noise that comes from an adjustment makes it sound like it's more invasive than it is, but by and large, incredibly safe treatment. And if you can avoid going under the knife, I don't know why you wouldn't.
Absolutely. And Doc, going into the manipulation, for those that are just listening, I'll talk through this. Those that are watching, even better. So anytime you feel a gas release, especially in some of the joints on the sides, the lower back lumbar spine specifically, the joints are almost forward and backwards or in a sagittal plane. As they get closer to the tailbone, they splay more outwards. So that's where we're referring to in terms of joint specific movement. Now, anytime you go into chiropractic adjustments or manipulation of the spine, especially from a chiropractic standpoint, there's a few different ways that you can go about it. The main ways are if you lay on your side, and if a bone or joint is twisted, putting either pressure on that disc or nerve. If you either affect the area above or below, you get a pop release, or even no popping itself too. Any type of movement will help re-regulate the tension within the joints, thus ease up some of the muscle guarding, especially from the small muscles along the spine called the multifidi, which we'll get to here in a sec. And that will also help more or less a pumping action to help bring the bulge back to center and take pressure off the nerves. But there's needs to be a repetitive frequency in terms of the adjustment, because one adjustment, say 95 times out of 100, is not going to necessarily completely cure the disc bulge herniation. So that's where, when you look at manipulation, they're very important. Versus a microdiscectomy, How they usually go about that is they cut straight into the skin, usually on the backside. And for surgeons, I might be saying some of this wrong, so I apologize. I'll have a video up that kind of shows you a couple small things, a little bit more in depth with that. But they can take out sides of the disc. There's different ways to help. If they do that, they want to make sure there's no compromise to the system. But when I was going through a few of these videos of how they can help with some of the disc problems, I'm sure they think about the muscles and tissues related, but especially the small multifidi muscles, which control the regulation of certain positions of the spine. And if those aren't addressed, either PT afterwards, the prognosis long-term or the chance of risk for other disc herniations below or above are going to increase significantly from there. So those are just a few things to pay attention to.
And I think also the reason why we're talking so much about the smallest tissues is because they play such a role in stabilizing the spine. And why that's so important is when we have disc issues or joint issues, it's those tissues that actually help to regulate strength in that joint. And I guess for those that are maybe having so much struggle managing their low back pain, their disc issue, and they just feel like it's taking forever, more than likely it's due to the fact that you don't have that grade of stability. And we find the ones that have a longer struggle to improve and to get over something like this, it's because they'd had no stability to start with. And whether or not you had a surgery that affected that, because surgery is something that can, there are still things that can lower your ability to have that kind of stability. Sitting for long periods of time is one, and I'm sure we'll get into that too. But Doc, anything on that?
Absolutely, really solid points there. I think there's certain areas that most practitioners don't think about in terms of the healing and recovery process, especially those individuals that work for post-operative cases. Obviously, you want to limit the progression and being very cautious when you first start off with. But the point that Dr. Addy made with the multifidi and the small muscles that connect the vertebral bones throughout your whole spinal column, they are one of the first communicators of the nervous system to the brain, and how the nervous system communicates to the body. It starts at the joint level or at the facets, and then in terms of the next line of communication, it then goes to the small tissues supporting and surrounding the spine, and then it goes to the nearby local tissues and or organs or other aspects of either sciatic pain going down the leg or communication of nerves down to the leg from there. So when we look at the communication of the nervous system, body, and body to the brain, the reason why, if they start addressing or cutting through those small multifidi, if you don't rehab or improve that communication back to the area, everything's going to be moving in a chunk or as a whole instead of one bone independently from one another, which thus has less risk of injury, and then also it accelerates the communication and the healing rate as well. So that's where certain areas of small rotational work or moving joint specific movement for the lower back specifically is going to be either forward and backwards. Very cautiously, I'd probably start with isometric contractions or squeezing the lower back glutes a few seconds on and off, and then go into a slight mobility work. After time, then you can go into stabilization. But very, very important for the communication aspect for the small tissues. Can't forget that as a priority.
Yeah, for sure. And Doc said we are going to jump into really an even bigger breakdown. And with that is going to come a lot of great statistics and information on just what that actually can do to you long term, having to go through something like that. The first study I have included here for as far as surgical intervention, this was patients with sciatica still experience pain and disability 5 years after surgery, a systematic review done in 2020. What they showed was prior to surgery, patients that had leg pain and disability, 75% recorded, let's see, I didn't read through this.
No worries.
Oh, this is a score. Baseline disability 5. There we go. Okay. They recorded some scores of what these patients were going through as far as disability and leg pain. Out of 100 being the worst, the leg pain was scored at 75 average throughout the pool. Disability was scored at 55. Now, following surgery, there was a rapid reduction in pain in the first 3 months. The pain scores dropped to about 15, which obviously that represents a great response. However, they also conducted long-term research to indicate, was there any real success with these interventions? And success is a word that's used so subjectively in studies. They'll say a surgery, let's say, for example, intervention was, yep, we followed up after 3 months and they're doing great. Yep, that's a perfect study right there, because in this study, they followed up 3 months and yeah, leg pain dropped to 15 out of 100 versus it was at 75. However, we live a long time on this earth, and by and large, there's just a lot of things that people forget when it comes to managing their issues, and that is, what is it going to be like down the road? And people just in so much pain. I get it. You're just looking for a way out, but you also got to realize you don't want to go through this again. You really don't. So long-term follow-up indicated a slight increase in pain over time, and actually at the 5-year follow-up, the mean leg score increased all the way up to 20, even 25 in some cases.
So it went back up.
It went back up. And this level of pain was persistent for most patients. Now, disability reduced all the way down to 15 right after surgery. However, disability did continue to decrease over time, which stabilized at about 13 after 5 years. So it did show that, at least disability-wise, there was stabilization. But the pain itself was what most people were still dealing with after 5 years. What they basically concluded was that patients still reported mild to moderate levels of pain and disability, indicating that surgery for sciatica, while effective, does not typically lead to full recovery. Why that's so important is, when we are going to intervene with surgery, there might be a time and place for it, but one of the reasons why, and we both know this, that there wasn't a full recovery is because you didn't address the more important parts of this issue, which is what we just talked about: the stability of the spine, the structural part of what's going on, and of course, all the other things that contribute to healing. And that's where you got to also double down on. And we'll get to a little bit on how we can improve that. But you can't just throw your eggs into surgery as far as a basket. You're not going to have the outcomes that you think you're going to get. And in fact, it might come back. And of course, if you end up getting a herniation again, you're back to square one. So, Doc, anything with that?
Yeah, that's really good. And I think even a point to make on top of some of this, and I think we're going to get to some of this later, but I just want to make sure we don't forget, is habits along the same way is going to be just as important. Because when we first start off talking about the risk factors of like obesity, if you don't address either the weight or the diet along the same way, or if you don't address the different types of movement throughout your day, if you find yourself either sedentary, sitting in certain positions, like that neck disc case that you brought up too, if those individuals aren't paying attention to their body position over longer periods of time, the discs are going to keep giving out and or compromise above or below where that disc surgery was for the long-term aspect. But those are a few things that you absolutely have to pay attention to as you go through after and also during the treatment for the discs as well. So, Doc, what have you found in terms of, does the research add up for orthopedic procedures itself?
And that's what I wanted to jump into as well, because, and this is just a small detour off of what we were talking about, but I still think it's important. Just showing the efficacy of orthopedic procedures as a whole. And this was a great study showing a pool of data, basically all orthopedic procedures thrown into this. And I think the study was 9,300 different orthopedic procedures across 3 hospitals. And the first thing that they found, and I'll preface before I jump into the stats a little bit, one of the biggest reasons why studies aren't that valid or helpful is because, one, they don't have, it's not a high quality study. So it's a low amount of people in the study. It's not randomized or controlled in any certain manner. Maybe it doesn't have a control, which means they're comparing it to something that has no effect. In this case, it would be someone who doesn't go through surgery versus someone who does. So you got to at least compare it to something to show where was the change in comparison to. What they found was the 9,300 procedures, when they were doing these studies, only a small proportion, roughly 20% of these procedures, actually had a randomized control trial supporting the superiority of this treatment.
Wow.
That's a problem because they're basing this incredibly invasive procedure off of very little research still. It's high quality research.
Yes.
Not to say we don't have a lot of it, but I get annoyed when people come at me saying we don't have a lot of research for our means and what we do as a living. And I'm going to throw it right back at them and say, look,
sure.
you say that you're evidence driven, but when you take a look at even all orthopedic procedures, we really don't have a lot. Only 36% of the procedure volume was supported by at least one RCT, showing surgery was more effective. That's almost just a third of their evidence actually shows positivity, and
Wow.
shows that high quality positivity, at least one RCT. A lot of basically what they're saying is a majority of surgeries out there are performed without robust evidence.
Yes.
And just that alone you should question everything before you do surgery.
Yes.
It's not just something that has been done for periods of time and they have just the highest amount of evidence regarding your outcomes. There's a lot of issues. Lastly, I think it had showed there was a high risk of bias in a lot of studies, just meaning that there was probably those involved in the studies had a underlying reason for it to be positive. And when that is the case, there tends to be a sway in the data when there is bias incorporated with the study. Well, those are the kinds of things. Other than that, I think, there's a lot more that I can get into, but it can be redundant. So really, we need way more high quality RCTs for all orthopedic procedures, including low back surgery, moving forward, before I have any confidence. But I already know what to expect. We've been doing this long enough. I would say the last place I would tell a person to get a surgical procedure done is going to be on the. I don't know. That's my 2 cents on that.
Absolutely. And I'm sure some of you that are listening have heard of a friend, family member going through surgery, and oftentimes it can be successful. It can help for a period of time. Others notice that it was really bad for them. And I think that comes back down to some of the stuff in terms of either habits, lifestyle factors, addressing those just as much as having the surgery done. But looking at some of these numbers, even myself, I knew surgery was the last line of therapy that you want to have done. So I'd suggest for sure going through conservative treatments prior to will have a way better effect, whether it's seeing one or multiple providers before even having that chance or opportunity to go into surgery. And then also monitoring in terms of different MRIs along the way to look at the progression as well. And 9 times out of, I'd hope 10 out of 10 times the surgeon would want an MRI so they could see even more in depth of what is specifically going on, other than just saying, okay, these are symptoms, maybe looking at an X-ray and saying, okay, we should get a surgery. I've heard that once and it blew my mind, without having MRI or CT scan or any in-depth scanning to see what's going on there too.
That's malpractice.
Yeah.
Plain and simple.
Absolutely.
And so you should be aware of the implication of things before you go into them. You should also have the knowledge to know at least what are some of the things you could expect from a higher quality provider who is managing this case too. So good point, Doc.
Absolutely.
The last thing I'm going to go into with this next study is just they broke apart the 5 really well done studies on low back issues and I believe surgical intervention. And I'm just going to very briefly go over each of those because it really did break it down in this big review that they did. And the first one was Weber's RCT done in 1983. And the reason they included this into this review was because it was just so well done. It was a randomized controlled trial. And what it showed was by the 4-year mark, comparing surgery to conservative treatment, differences in outcomes had diminished, meaning there was no benefit anymore statistically in surgery versus conservative care after 4 years. What it did find was, yes, in the short term, surgery was faster, but we always are looking for the quicker fix. And I know those of you listening out there, anytime you've rushed towards a quick fix, you don't get the outcome you're looking for. Losing weight, it comes back. Trying to get into the gym and getting that quick burst, but then you don't actually end up finishing your resolution by the end of the year. And you're never thinking long term when it comes to those kinds of goals. And I know we've talked a lot about that, but you can't forget the other research out there showing what to expect after you go through something like this. And again, if I'll finish this before I get to my point, which is Osterman et al. In 2006. Small study showed microdiscectomy versus PT showing improvements in surgery on leg pain, but no significant long-term differences in back pain or quality of life after 2 years. I'm going to keep driving this home to you guys. I know this is redundant, but I need you guys to understand this. The next research focused on timing of surgery, found that early microdiscectomy provided quicker symptom relief than prolonged conservative treatment, but both groups had similar outcomes by 1 year. This is not even 4 years. This is 1 year, showing that surgery even after 1 year wasn't as effective or just as effective as conservative treatment. That's not a lot. That's not a long time. And to go through, actually, I keep wanting to get to my point. I'm going to get to these next 2 studies, and then I'll finally drive home my point. The main lumbar spine study, MLSS, this showed up to 10 years they did. And study showed surgical treated patients had better outcomes in terms of pain function satisfaction at 1 and 5 years. However, differences narrowed by the 10-year mark. Both groups showed similar work outcomes. The observational design suggested surgery provided more immediate benefits, but not necessarily lasting superiority. I don't understand how they did the 1 and 5 year mark, because all the other research that I've seen showed by 1 or even 2 years, there was no change. So I'm interested to see just the change as far as 5 years out. But the last one is a sport trial, which one of my favorite. This is a very large study, and it showed surgery provided greater, faster relief across primary, secondary outcome measures compared to non-operative. With sustained improvements, however, there was high crossover rates between treatment groups, meaning those who were doing conservative care ended up getting surgery anyway, and then those who were doing surgery ended up needing more conservative care after, because nothing was working as well, underscoring a challenge of maintaining strict non-operative management in such trials. So really and I'll get to the outcomes of the sport trial in just a little bit too, because there's a lot more that I want to break down. But what I wanted to drive home was the risk of doing lumbar spine surgery, and especially with microdiscectomy. You're going to interrupt such crucial structures in the spine doing this. And this risk carries a lot of problems down the road that you're going to have to address anyway. And it's going to maybe even make them worse, because if instability was the problem, and then you go in and tear up more multifidi tissue to get to the disc, that's only further making it more difficult for you. So to show that you're going to get outcomes in the beginning, yes, we're not arguing. Surgical intervention for this in the short term will more than likely give you some relief. But long term, you're just going to continue to have to deal with this. So is it a cure? Is it a fix? Is it what the surgeon tells you? Because if the surgeon tells you it's going to fix it, it's going to cure it, they're lying to your face. And that's what I struggle with. So you need to understand that, yes, it will help you in the short term, but you're going to deal with this after the surgery. You're going to plateau, and you're then eventually going to need PT anyway, chiropractic, whatever else. But that now changes things for you, because if you have altered structure from this surgery, it's only going to make your job in here harder and our jobs harder to help you, because now we're fighting an even more difficult uphill battle. Doc, anything with that?
Yeah, absolutely. I think for some of those people, if you're listening, if you're in the boat of maybe you've tried some conservative care, maybe surgery is the only route and option for you, there's one thing that I would suggest significantly: talking to orthopedic surgeon or getting a second opinion, just as is important as finding the provider on who you're going to have your rehab afterwards with. Ideally, in a perfect world, having communication of the surgeon with the provider prior and post. I know it's a little bit overkill for those people that are just used to, oh, they had the surgery, okay, now let's find a provider. You have to go into it knowing what will happen, ask all the questions, not only for the bone structure, but for muscle and tissue structure, and asking the questions of how is this going to compromise my system? What are certain specific things in terms of therapies and or treatments that you can do afterwards? And what are the options? If they just give you one, ask for more, so you can have you have as much detail going into it and knowing what it's going to look like going out of it as well. And that's where, when people are getting out of surgery, okay, now I should do PT. Some people don't, and it just blows my mind, because some of these studies are showing it good short term, but unless you address the tissues, the structure, the compensations above or below long term, you're going to end up where you're at, or even worse from there. Obviously, it's showing that. So whether it's finding either a physical therapist or a chiropractor that understands the muscles and tissues and can do some physical therapy rehab, I would suggest either those two. There's definitely some other providers as well, but you want to find someone that has experience dealing with post-operative cases. Usually physical therapy, they have a lot of schooling in that area, so that's usually a commonality. But there's other providers that can have just, if not better, results long-term. And whether you're shopping around, asking people, going in for an exam, saying this is what I'm dealing with, I'm looking to go into it. And then if you haven't done conservative care prior to, then I would suggest that prior to surgery. And if a surgeon is going to be completely upfront and honest with you, they're going to want conservative care before surgery. If they just say, let's go into surgery, I would start looking myself at a different surgeon, unless they can explain the reason why even more in depth. Like, there's certain cases of that there could be compromise to either the nervous system or the structure that you almost have to go in sooner than later without conservative care. But even then, and those are very rare and very few, those are just a few things that you want to pay attention to pre and post surgery.
Absolutely.
Okay,
Yeah, can't stress enough the caution I would take prior to doing something like this.
Mm-hmm.
But I do know that this kind of pain is debilitating, and it really can maybe cause you to create a rash decision versus the patience it takes to really go through and allow this to heal by itself. And that's right where we get into this next topic here, which is, can actually the herniated discs heal by themselves? And really what I want you to take away from this is yes, actually they can. Now, it depends on the kind of herniation or change in the spine. And Doc, if you maybe just want to touch a little bit on the difference in what the disc can do as far as change in both circumference, but also if it's a protrusion or extrusion too.
Absolutely. So there's a few differences of how the disc and where the disc comes out. Much like Doc said, does it come straight back to the spinal canal, pinching nerves? And is it just like a small, those people are watching, a small little bit of protrusion backwards? Or is it either circumferential, where there's a huge opening and there's a lot of give on that whole, let's say, a third to even to a certain extent half of the disc, that is completely either going outwards, almost like it's squished to a certain extent? That all has to be treated differently. And there's a few things, even in addition to that, we want you to pay attention to. There's specifically ligaments that are holding the front of the spine and the back of the bone vertebral body. and they help stabilize and support not only the discs together, but help stabilize the whole spinal column as well. So if there's give whiplash symptoms, if there's any traumatic injuries, that can cause give to those ligaments, which then also increases the lack of stability and higher increased risk of discs, which then can force different compromise of how these discs can go more times than not back to the spinal canal, because the ligament on the front side is a little more thicker and a little bit more robust stabilization wise, because of, for the lower back and even the neck specifically, there's vital organs that are on the front side, so naturally the body wants to protect not only those but the structure, versus the back side. And certain positions over time will limit the stability, whether you're sitting, whether you're bent over for longer periods of time, which will compromise the ligament on the backside, known as posterior longitudinal ligament, or the front one, anterior longitudinal ligament. So it depends on, is there going to be a slight bulge or a small part of the disc going straight into the canal? Does it go a small area, or does it go quite a bit more into that canal? And or is it circumferential to where not just a small area is going back into like a bulge, but it's more of a herniation in terms of more of the disc is going backwards? And that's broken up into the percentage or the degree of where it goes back into the spinal canal.
Yep.
And there's a lot of specifics with that, but some of that's, I don't know if we have to go too in depth, but that's where certain MRI scans come in play.
Yep.
More so than anything else.
Yep. And the 4 different types that we'll break down is a bulge, which is just the, like Doc said, it's kind of more of look like it got squished. The second is an extrusion versus a protrusion, which is just different depths of the disc being herniated. And then sequestration is when it actually protrudes so much it breaks off from the disc and it stays into the spinal canal, which that can be quite painful too. So what they found was the probability of any spontaneous regression and healing is actually 13% in bulging discs. 52% of protruded discs actually show healing, spontaneous regression. 70% of extruded discs and 93% of sequestered discs show this kind of already spontaneous regression. We see over half start to heal by themselves without really any intervention. Some research actually shows up until 6 months, it can be completely resorbed by itself. The complete likelihood of that is about 50% in extruded discs, 30% in protruded, and 6% in bulging discs. I actually think it's incredibly high in sequestration too, but I don't remember that. It doesn't have that here. But what's interesting is most people, and I hear this often, is I herniated a disc back in 1982, and I've been dealing with it ever since. And people don't understand that these actually will take care of themselves. And so when you come into me and when you say something like that, I then challenge the patient and say, "Oh, this is the evidence. This is what we actually know." So we know that your 1982 disc injury probably took care of itself by about 6 months, maybe a year or 2. Question is, why are you still having pain? And then they look at me, and that's when we start to talk about what the real reason of your pain is. And not to say you didn't have pain from your herniation, but now why are you stuck in this loop, and why haven't you actually addressed what was the real concern? And we know the chicken egg is if there was large amounts of instability prior to the herniation, that's more than likely what caused it. And so if we aren't addressing the instability, that's going to be a huge predictor of whether you heal or not, to the extent that you want to, which is why we're driving home this conversation so much, and why we really want you guys to understand this. I don't think there's really much else as far as follow-ups on that study. We could maybe jump into conservative care.
Absolutely.
Sure.
Ooh, actually, I did want to bring up one case. I can't remember exactly what the scan said. It was like buckling of a disc is where the disc got protruded backwards into the spinal canal. But in terms of, if you remember the ligament that I said on the back side of the vertebral bodies, where it protects the spinal cord and the vertebral body itself, that the disc actually went in front of or between the back ligament and the vertebral body. So it almost got brought into that space where that ligament was holding due to laxity. And this patient was a smoker. There was complications like for a large period of time, but I think they said it was like a buccal disc or something like that, which I've never seen before. She's definitely looking at more of a surgical route because all areas of conservative care were limited just due to not having the proper stabilization and support of that disc going back into its normal space.
That's also a rarity.
Oh,
I
very
mean, incredibly rare. But I remember seeing that case too. That was super interesting. That was the first time I'd ever seen something like that.
Same. Didn't even hear about it in school or anything like that. So that was unique. But yeah.
So when it comes to outcomes for non-surgical treatments for sciatica, there were a few things that they looked at with this one study, and they discussed, again, leg pain, disability, back pain, quality of life, satisfaction, all the things, I think, up until 12 months. The first line of treatment that they recommended, first and foremost, was strengthening and flexibility exercises for pain management done via physical therapy, exercise, and in combination. That absolutely needs to be done first. NSAIDs, pain relievers, muscle relaxants were commonly used, but were only able to get short-term periods of relief, alongside, obviously, PT. Steroid injections offered modest but short-term relief, but actually lacked sustained efficacy. Manual therapies like spinal ablation, traction massage all showed moderate short-term relief, but required ongoing treatment for lasting effects. Now, this study, we don't have, I would say we have way better research now compared to this study for spinal manipulation. We obviously just went into that too. But with this one, I really just wanted to preface the need for looking at interventions, first line of PT or exercise first before you do something like surgery. And again, whether or not we even do surgery, that's another argument. But when it comes to managing low back pain, we all know that there's so many things out there that you've maybe tried that's helped in the short term, especially even maybe into the mid to long term. Things like acupuncture. We now know that with certain back pains, we can even do like cognitive behavioral therapy, certain psychological things too. But in regards to sciatica, it is a lot more structural than I think people think about. That's where really making sure that you focus on the strengthening, the flexibility, the exercises, doing adjustments. That's where you're going to get not both only short-term, but long-term outcomes. And I can't drive that home enough for people listening in. And if you haven't tried that yet, then that's something I think you should definitely look up, managing this moving forward. Talk anything with that.
Yeah, so when we look at where discs come out and where they're at, usually you'd want either a practitioner that can do certain areas of testing to see, okay, does a disc come out at this level? In terms of testing, there's certain limitations that you can see, whether it's sequestered, whether it's a bulge, whether it's a herniation. That's where MRI usually comes into play. Now, when you go into that, let's say we know that there's, for example, a disc bulge going just straight backwards into the spinal canal, and it's impinging off of either pain going down both legs or even one for that matter. To get that disc, to bring that back to center, to accelerate the healing other than having it to heal itself, you would want ideally extension type exercises, and some of this will cause a little bit of pain. Doing this alongside the overlook of a practitioner is ideally best with all this, because there could be other symptoms that can come up from there. But if you go into a cobra, or you extend your back, whether it's standing, whether it's laying face down, it will force a pumping action of bringing that disc back into its normal space, which will thus accelerate the healing. There's other things that you could do in terms of traction, like lumbar or neck traction. Now, there's certain caveats with that. If you go into traction, oftentimes it's a type of therapy that sometimes insurance companies don't necessarily cover it, so it's more of a cash-based services, but it actually works for most people quite well in terms of lowering or tractioning the pelvis from the mid-back. And the caveat with that is if there's guarding of muscles and tissues around the area, it'll increase the stretch reflex of those tissues, which if there's guarding deeper in the area, you're going to get a little bit of movement, but not completely everything of what they say, just because of the guarding mechanism of the muscles. So when you go into the tractioning aspect, I would suggest not right away, maybe give it a few sessions, light squeeze of your core, or let's say we're doing traction of the neck, trying to squeeze lightly like an isometric contraction, whether it's your jaw, neck muscles, as everything's lengthened, to have communication of the nervous system to those lengthened tissues, just so there's going to be a recoil of them coming back to center automatically, but the body's going to have awareness in terms of a lengthened state of not only the bone structure, but also the muscle structure, to also help for the less of the guarding, will help the signaling of that specific area and those tissues locally to help the body naturally force that disc into play. So that's where traction works well. Segmentation after a period of time, as the pain starts settling down, less pain going down to legs, you can then start moving, specifically lower back this is. You can start moving to extension and flexion, but ideally when you first start off, extension exercises, forcing the disc back into place, but then sagittal segmentation, or you slowly start bending all the bones all the way from top down, will also bleed energy to the ligament on the backside, just to stabilize that ligament to hold the discs in place, and that's going to be further on down in the treatment. But that is a specific way that you can go about it. Or you bend down, touch your toes, squeeze your core like an isometric contraction as we're into flexion, and then have someone either tap or yourself tap on your lower back, exactly the specific area where you had the disc herniation, and or to a certain extent surgery, to also help for the stiffening of that ligament. So those would be a few things that I myself would start looking at, but again, you need overview of a practitioner through this process ideally. But if I had a herniation, those are a few steps I would look at. There's obviously a few others, but some of the main ones that will work really well.
And there's another reason why you'd want a physician on your side before you started doing something like this is because if you feel you have a herniated disc, but it might actually not be, that's incredibly important too.
Yes.
And that also helps to cut off an unnecessary or a not necessary surgery that you might have to you go down that road without actually needing it. These are I would say five or six common mimicking associated symptoms of conditions that act like a herniation or act like sciatica, but isn't actually sciatica. And so you also have to know, as practitioners, we have to know what these conditions are in conjunction and similarity. But it's very important because so many patients do come in and they'll say, "Oh, doc, I got sciatica. It's going down the leg, and I think I'm worried about it." And so we dive into it and we figure out that it's actually SI joint pain or facet pain, or it's a hip issue, not even a back issue. And so I can maybe just throw up this chart here without actually going into all of it, but that's why we want to make sure you aren't experiencing what you think you're experiencing, because if you were to go through with surgery, and there are times where there's even fake outs where providers will actually see something on an MRI and then they actually assume it's that. We know that not all, like Doc was saying prior, not all bulges, herniations cause pain. More likely a bulge, maybe less than a herniation. You are having back pain, MRI is ordered, physician sees that there's a bulge. Yep, that's what we're going to treat. Let's move forward with that. However, we know that if that's actually not what's causing your pain, instead maybe it's instability, maybe it's compensatory postural change, whatever, sometimes it's even psychological, then we got to understand how to stop you from going down this next road of what happens if I do go through surgery.
So, Doc, if you were to go through surgery, what are some of the things that you would want to pay attention to? And I know we touched on this a little bit ago, but are there other things that either questions to ask surgeons or conservative care like physical therapists, chiropractors, for these disc issues?
Yeah, I think the study that I provided will explain a lot about the muscle morphology of multifidi tissue that I think we really want you to understand before going into any type of discectomy, a surgery. And before I preface that, I think to answer your question of what things to ask your surgeon, number one, ask them, will this fix me? And if they say yes, it's a red flag right there, because they should be evidence forward enough to know that no surgery will fix anything in regards to musculoskeletal issues. Very rarely. We just cover that in obviously that big orthopedic review. So they're already being more of a salesman than a provider, and that's already a red flag for me. If they do say we will find this might give you some benefits in the short term, but there's still some things that we need to do long term for your success, that's huge. Green flag.
Yeah.
Big time. And especially even if they have worked with other PTs or chiros and they're already ready for that referral because they just know that's what's most helpful and important, or super helpful. So that's where you can feel a little bit more comfortable. If unfortunately, if that gets to be a point in time where you feel surgery is what's best for you, but we're still both going to caution on the side of error with that. Now, if you do end up going through surgery, there are some things that you do need to understand, and that's exactly what we've been talking about this whole podcast, which is the changes to those small tissues around the spine and what happened. This study identified association between the changes in the multifidi tissue and the level of back pain experienced by patients post-discectomy surgery.
Wow.
What they found was there was multifidi atrophy, or a reduction in the size of the tissue, and it was very frequent after you get discectomy surgery. And we already know that muscular atrophy is a huge link to increased back pain in patients. So we're already going to have an uphill battle after this. And that's what we've been telling you. We've been telling you guys this is what's about to come. Now, research shows that there are patterns of degeneration within the multifidi muscle that often correlate with higher post-op pain and disability scores. Now, the impact on disability also was increased in patient reporting, indicating that your quality of life and disability might actually worsen after you have the surgery because of just how much the multif really impact your ability to have a stable spinal column. As far as preoperative muscle condition, patients that had a healthier preoperative condition of multifidi tissue were more likely to experience less degenerative change and lower pain scores post-op. So meaning if you worked out, you had a really great stabilized spine, you did exercise, those kinds of things, your chance of having less of a atrophy or a change structurally was going to be improved. So what that tells us is if you already are struggling with a low back issue, herniation, you got to start strengthening that back. Because if surgery is something you're going to have to lean on down the road, your outcomes are only going to be better. Rehabilitation, targeted rehabilitation to address muscular degeneration post-surgery for exercises focusing on strength and multifidi. They highlighted just how incredibly important that was and why you're actually going to be getting better results if you were to do something like that. Just basically, finally, study suggests that surgical techniques might reduce the impact of the multifidus muscle, potentially lowering postoperative pain and muscle degeneration. That's just more of if the technique was less invasive. So if there was a surgery, if the option was surgical and they can choose something that was a little more less invasive, obviously that's going to help you just so that they don't completely demolish the tissue surrounding the spine as they went in. So yeah, Doc, anything to say on that?
Yeah. So when you're going through some of the multifidi, if I'm paying myself, if I was in that same situation to where I've tried conservative care, maybe didn't help, now I'm going to visit an orthopedic surgeon. I'm seeing, okay, let's say they had the MRI done, we have that up. I would ask specifically how you would go about the surgery, more for the reason of the local nearby structures, the small tissues along the spine, where they go in and how they perform the surgery, whether it's they either shaving off certain areas of bone, are they shaving off, or do they have to cut through small muscles and tissues? along the outsides, the back outside portion. I would want to see every step along the way, and then asking them along the way and prefacing, okay, so if you were to go through, either hold the spinal cord off just to shave off that disc, what does that do to the ligament on the backside?
Yep.
What does that do in terms of the stabilization of some of the small muscles around there? I would also ask, if going into this, do you have to cut or shave, or potentially cut or shave some of the small muscles? And if so, is it advantageous to build up some of those small tissues, or is it more advantageous to strengthen the areas above and below, more for the healing afterwards? So you have a general understanding of what specific tissues are being cut or compromised during the surgery. I would also ask post-op, let's say you would go have the surgery, know what's being done, you're waking up after surgery. I would also ask the surgeon, did everything go as we discussed previously, or was there certain complications during the surgery of things I need to pay attention to, whether do you have to cut or go through a different way or a different path? Are there other tissues or structure or part of the structure compromised? So you have a target in terms of what you want to heal and rehab in terms of physical therapy or conservative care afterwards.
Yep.
And that way they can more or less be very specific with the rehab. And finding a person that is specific is another challenge in itself, because a lot of times after surgery, they're going to get you back to going through general types of movements of bending, sitting, squatting. And if you can do some of that, they're going to probably release you. Just bare minimum stuff, but that doesn't necessarily, going back to the long-term aspect. If you're going to do this, ideally you want to do it right. And that's where you have to know what tissues or structures are involved so you can start healing those, whether it's time under tension, whether it's small rotational holds and isometric contraction squeezes with either tapping of the area so you have that mind-body connection for the healing of that specific level. Like you can go very, very in depth with some of this, especially like core to extremity movements, meaning anytime you move, walk, throw, jump, all the movement usually starts with the core and then bleeds out to the legs or arms from there. But those are just a few things to pay attention to.
Absolutely.
Lead into it. So
absolutely. That was great.
Well, this is my favorite one.
So
yeah,
I think this will be a great way to end. I know this is something that we enjoy talking about a lot. I talk about this probably every day with patients. And that is, should I get cortisone shots for my herniated disc sciatica pain? Now, I included 6 studies because I don't think one was enough. And it helps to give you this understanding of what to expect and what are you giving up health-wise to get this, and what is your journey going to be like down the road had you not done this. And too many times we find the same pattern repeated with patients doing cortisone for not only back, but a lot of other joint and musculoskeletal pain too. But number one, Boswell in 2003 found cortisone injections provided short-term pain relief in patients with lumbar disc herniation, but the study does not support sustained long-term improvement. It also noted that repeat injections might lead to diminishing returns on pain relief over time without promoting disc healing or resorption. And that's a big statement, because we really, Doc did a great job of driving home why physical versus chemical is so important. And if we are losing the ability to take care of that physical issue, then we are going to see chronicity with this condition. So what that meant was, I liked how they said it without actually being mean, but in the conclusion, what they said was, if you continue to do these kinds of injections, you're going to limit your ability to heal this disc. And you might actually, quote unquote, freeze it in time, which was a way that it was explained to me at a seminar that I had seen pre and post MRIs of patients getting cortisone injections. And I did see on the post MRI 6 months, where usually we want to see a huge regression, there was absolutely no change in the disc protrusion via a cortisone injection frozen in time. And so you really are giving up a few days, maybe weeks, if that, of relief for now an even bigger uphill battle trying to take care of this issue. Kang, 2011, investigated different dosages of cortisone. Results showed short-term pain relief. However, study did not support prolonged benefits and did not indicate that cortisone affects the natural healing process positively. Again, super nice way to state it. Zhao in 2020 conducted a meta-analysis comparing steroid injections combined with lidocaine. Addition of steroids provided marginally better short-term relief, but no significant improvement was seen. Suggests that there is a limited impact on the natural progression and resolution of herniated disc using steroids. Again, number 4. This is a sport trial. Observed that patients who received steroid injections had lower rates of disc resorption, meaning there was a lower rate of healing regarding when used steroid injections, suggesting that cortisone may limit the natural healing response. This finding raises concerns about potential long-term implications on disc health. I'm going to keep going. Number 5. Manchaconti, 2015, reviewed efficacy of steroid injections for herniated lumbar discs, finding consistent short-term pain relief, but insufficient evidence for long-term structural or functional improvement. That's interesting too. Study suggested that cortisone could impair immune-mediated resorption processes critical for disc healing. I'm going to end it with number 6 because I think I'm finally proving my point. Benoist, 2012, emphasized the role in inflammation promoting disc resorption, meaning you need inflammation in this process for your disc to heal by itself. Suggested that cortisone's anti-inflammatory effect, while beneficial for pain, could theoretically inhibit this natural resorption, possibly prolonging the presence of the herniated material.
And that's where, oh my gosh, there's certain practitioners that only have so many tools in their tool belt to help with the problem of a patient coming in.
Yep.
If they don't have any other areas of treatment, ideally it would be best to refer out.
For sure.
Then it goes to the business side of things. If they're not meeting their quota, they're not, whether it's a bonus structure, whether it's something for their pay, like they're almost incentivized as a business being, okay, this may help. This is the only thing that we have, instead of referring out and being efficacious to the patient itself. It's almost borderline irresponsible. There's a time and place for steroid injections and cortisone injections, but in terms of spine, discs, it's almost a red flag to hear a practitioner, or you go into a practitioner, they say they want to do a steroid injection. I would start asking, okay, what are some of the complications with this? And if they don't know, or if they say there's none, huge red flag. If they don't refer out or have someone monitor their case just as the same time, God, it doesn't make sense. Yes, it can help pain-wise, and if they're only focused on pain instead of long-term function, I wouldn't even look to see that practitioner in the first place.
Yeah.
But yeah, this is your body long-term. Yes, if you need pain, there's probably certain circumstances. Let's say you're a professional athlete, you're in the playoffs, you're going for like the championship or whatever. Even then, I'd start questioning it. But what's the risk?
Yeah, because again, you're still gonna have a life after sports, and
Yes.
I get it. This is your job, and this is everything you've trained for your entire life. But I think for most people, this is something that will continue to affect them long term if they don't do the proper interventions in the beginning. And really, what we really want to, and I'm sure you've finally got this message if you listen to the entire podcast, which is you are giving up a lot of health in a way to have these interventions done, whether it's cortisone or surgery. And yes, you might get some relief short term. If that's just truly your goal, then I have to already question what your motive and thoughts are, which is you got to be stronger than that. And you gotta look out for yourself, knowing that this is something that you're going to have to take care of way after the fact of the disc finally healing. And let's say you have a family to take care of, and let's say you have yourself to take care of, and you're trading in 2 weeks, maybe 3 months of relief for now an even more difficult uphill battle after this. where you could have just started with conservative care and the same outcomes would have happened 2 years out from whether you had surgery or not. And I think that's where people need to rethink this intervention just for this issue. I'm not saying that there are other things that surgery can be helpful for, but for this particular one, it ain't it. It ain't it.
Yeah, just because they have a doctor in their name doesn't mean that you have to take everything that they say for granted.
Yep.
You have to be curious. You have to ask these questions. Or like there's certain things that practitioner can have a rough night, could have some stuff going personally. That's something that they typically do. There's certain small situations that can affect the overall long-term care of your body, your health long-term. So eliminating those small things, asking questions as much as you possibly can, getting multiple opinions.
Yep.
But yeah, for discs, conservative care, hugely important before even looking at surgery, before even looking at steroid injections. Yeah.
Yeah. And I think I provided one more graph just explaining the interventions in detail. What was interesting is one of the interventions that they actually put as likely to be beneficial was spinal manipulation. That was the only approved intervention that was a non-drug treatment for this issue. The other ones that were unknown effectiveness was acupuncture, advice to stay active, exercise, heat, ice, and massage, which is interesting, given that PT and exercise is something that we would obviously include in our own. I'm just curious to know what research they found where they found it to be unknown effectiveness. But unknown effectiveness,
exercise therapy,
antidepressants, corticosteroids, muscle relaxants, unlikely to be beneficial, NSAIDs, likely to be beneficial, short-term benefit, microdiscectomy. I'm glad they put in short-term. Unknown effectiveness as far as discectomies, laser discectomies, percutaneous disc compression, and then covered elsewhere in clinical evidence, obviously with chronic low back pain. And we talked on the Lancet study, which showed all the other interventions that they recommend for just chronic low back pain, not actually herniations. But for conservative care, there's a lot of things that I wished to have included in this podcast, but just due to the fact that anytime we talk about some of these alternative measures, we actually are censored on YouTube. So the fact that I actually wish I could have given you a lot more conservative care options for this, but maybe go back to some of our other podcasts. I know that we've touched a lot on them prior to, and I think you'll know what I'm talking about when you maybe go back 3 or 4 of them. And yeah, so we really chose not to talk about some of the other ones today because we really do want this information to get out to people to help the ones who need it. And so yeah, there are definitely other things that I would recommend handling these kinds of conditions, and would just emphasize that you guys look at those that we've talked about in the past too. But Doc, anything else?
Yeah, I'd say the brief overview, if you have sciatic pain going down your leg, I would suggest going to either chiropractor or physical therapist first.
Yep.
Outside that, like I would try to stay away from a medical doctor just because of the tools that they have. Not saying that they're bad. I think there's a time and place for certain practitioners, but that's just a nice rule of thumb in terms of the brief overview of everything. There's a lot of other specifics involved there, but yeah, I think we touched on a lot of different areas quite well. Obviously, if you guys have questions, leave them down below. We're not going to be able to answer every one. If you're in that situation, or if you present with this and this, what do you have? I would go see a practitioner. But if there's certain questions you have on any areas of the research or any other things that can also be related, leave that down below. What or certain things that have helped you to get you out of pain? Because even certain people will read the comments, and if you put some stuff there, I mean, it's worked for you, they might get good relief. So you're paying it forward to other individuals that have seen some of this. So I'd suggest
trying to build a community of that. That's our entire goal with this. Perfect, you guys. Thank you so much for watching and listening. We really hope that this was super valuable for you. This is something that we truly love to talk about because it is something that impacts a lot of people in such a negative way. Thank you guys so much for listening. And until next time, Doc, we'll see you guys later.
Woo!
Disclaimer, the content provided in this health podcast is for informational purposes only and is not intended as a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified health provider with any questions you may have regarding a medical condition. Never disregard professional medical advice or delay in seeking it because of something you have heard on this podcast. If you think you may have a medical emergency, call your doctor or 911 immediately. Reliance on any information provided in this podcast is solely at your own risk. The creators and hosts of this podcast are not responsible for any actions or decisions you may take based on the information presented.
Thanks for joining us on The Functional Code. For more evidence-based health insights, subscribe, rate and review wherever you get your podcasts. Remember, your journey to a healthier you begins with understanding the Functional Code. Until next time, stay well, stay informed, and embrace the science of living well.